So welcome. So does everybody know what a clinical audit is? Yeah, that's 100% right. 100% right. I'm just trying to get this thing into read mode, but now I've got the Zoom thing in the way. So I'm still learning how to do things. All right, I guess we'll just have to look at it this way then. Not much else I can do. I hope you guys will be able to see it properly over there. Try and make it as big as possible. Yeah, so basically that's what a clinical audit is, you know. So we look at ourselves. It's similar to research. In fact, let me post this on the group in case you guys have difficulty seeing it on the, what you call it, on the actual screen. I know it's not the best screen, unfortunately. So let me just share it on the, yeah, so instead of doing research that betters mankind, we basically look at what we are doing and we try and make sure that we're not messing up too bad. And where we are messing up, we try and cover those gaps, all right? So that's basically what a clinical audit is, all right? So it should come up on the group any second now. So in January, what I had a look at was how we've been managing diabetes, all right? And I say diabetes, not just, sorry, let's close it up. Not just hyperglycemia, also hypoglycemia. Most of our hypoglycemics are diabetic as well, right? So it's just to have a look at how we cope with them, how we manage with them, and then to take it further from there. So let's try. I'm trying to really make that right. Okay, just get it like that. Here, sorry, I'm learning as well. All right, so the way that we do it now, this is all just the aim and things like that. So the aim is to analyze diabetic emergencies. In this case, it was because of the large number of DKAs we were seeing during the COVID-19 pandemic. Okay, my apologies for my voice. It's just gone a little bit. Also lost my sense of taste and smell, but I don't think it's anything major. Don't worry. Okay. No, no, I'm just kidding. Don't worry. So what we did, I took 8 patient files. All right. These are all patients who came from mid-December, mid-January 2021, and we scrutinized their records against 5 criteria. Now the criteria are determined by our protocol. Okay. So I was trying to bring up this workbook, but for some reason I just couldn't find it. I don't know if I erased it or what it is, but this is basically what we're looking at. So I know everybody's got to kind of turn their head a little bit, but these are our 8 patients. So the criteria we used were, was it a correct resus? In other words, did we start off correctly? Did we maintain the patient correctly? Did we do the correct investigations? Did we dispose of the patient correctly? Now, disposition means did we admit correctly, ICU to the ward, things like that, and did we have a good outcome? And you can see we actually did quite well. There's a few things where we made a few mistakes. So how the thing works is that if we did well, green. If we did bad, red. If something was not applicable, for example, then it would be yellow, all right? So that's not in this audit, but in next month's audit, the February audit, we didn't do as well, unfortunately. But this one we actually did quite well. And then we work out the percentage, how we did for each patient, and then how we did for each category as well, right? So there's certain things we did very well. So for example, all our patients had a good outcome, all right? We had one patient where we sent to the ward instead of ICU. So these are the things that we're going to look at, all right? And it's not going to be very long. I'm going to try and keep it as short as possible, just so that we can get the ethics point, and then we'll do a small, a little true and false thing at the end, right? So the question when we are doing correct resus for hypoglycemics, we're asking ourselves, did we give IV 50% dextrose immediately, right? The reason being, sometimes when we get hypoglycemic patients, some people have the tendency to put up an infusion of glucose, all right? An infusion of glucose takes quite some time to work. That's the reason we have 50% dextrose, that we can get the sugar up as quickly as possible, all right? And if the sugar is not going up, then ideally you want to continue with an infusion. If it's still not going up, you give glucagon, which we don't have in stock, but that's ideally what you'd want to do, all right? And then to make sure that you correctly look at your HTTs and things like that. And for hyperglycemic patients, where bolus is done in accordance with the protocol, The thing is, with diabetic patients, we'll do a presentation on diabetes itself. The worst thing you can do is give them too much of fluid. And the other worst thing you can do is give them too little fluid. So the question is, how much of fluid do you give them exactly? All right. So we'll go through the protocol of it just now, right? The problem is if you give them too much of fluid, when you've got all that sugar sitting in their vascular system, sugar is an osmotic substance, all right? So it starts pulling a lot of things across, okay? So what happens is that within the brain, you suddenly have this brain cell that's having all of its water pushed out. Now, that happens with all of your cells as well, okay? So you have all of these things being pulled out in a highly osmotic way. And if you flush too much of fluid in at the same time, now you've got the opposite occurring. You have this highly osmotic area becoming a highly hypoosmotic area. So all the water starts rushing back the other way. So your brain cells start to swell and you get cerebral edema. And it's just a basic of it, but that's why we have to worry about how much of fluid we're giving people, all right? We have to avoid that cerebral edema, all right? And was immediate insulin avoided until potassium levels were known? So can I ask, how many of you guys still have that habit? As soon as you see a high blood glucose, 10 units IV, 10 units IM? Nobody. Good. Because that's how it shouldn't be, all right? Remember, insulin drops potassium. So if you don't know the potassium, you can potentially kill your patient, all right? Now, lucky in our patients, we did quite well. 75% of our patients, so we complied with the protocols that are there. So in one patient, patient was given 5% glucose rather than IV dextrose, all right? And then one patient received intramuscular, all right, rather than subcutaneous. We don't give IM insulin. Nobody gives IM, it's always subcut insulin. And this was before K plus was determined, okay? But in both cases, we were lucky, all right? Or in this case, the patient didn't have hypokalemia, but we try and avoid it as much as possible, all right? The quality improvement plan is what we're doing at the moment. We're looking at it, we're talking about it in the audit meeting, all right? So was the correct maintenance done, all right? So this was what we had to look at. Were hypoglycemic patients kept on infusions of 5% or 10% glucose, all right? Were blood sugar levels monitored at 10 to 15 minute intervals to ensure improvement? Were hypoglycemic hyper started on any crystalloid fluid at an acceptable rate, all right? Now, the thing is, there's a lot of different protocols out there for how fast you should give your fluids and how slow you should give your fluids. But the one that I found works best, and a lot of people, well, actually most of the tertiary institutions are using the same one. You give 250 mils over 10 to 15 minutes, all right? So in other words, a quick bolus. You give them a quick bolus, and then whatever's remaining, you give it over the next half an hour to 45 minutes, depending on how dehydrated they are, because all your hypoglycemics are dehydrated, okay? So essentially within the first hour, you've only given 1 liter, all right? So you've given enough to start resuscitating the patient without exposing them to the risk of cerebral edema, all right? Then your second liter goes in after 2 hours. Your third liter goes in after over 4 hours. Your fourth liter goes in after 6 hours. So you've essentially given 4 liters over about 16 hours. But the thing that determines whether you're doing well is your urine output. Okay, so your urine output should be 1 mil per kilo per hour. So in other words, a 100 kilo person should produce 100 mils per hour, all right? A 50 kilo person should produce 50 mils of urine per hour. Now, let's say your 100 kilo person is producing 20 mils. You know that you can increase the amount of fluids that you are giving, okay? If your 50 kilo person is producing a liter now every hour, then you know that you are giving much too much, all right? So that's basically how you determine it, right? Now, when I say that, it's also a bit tricky because hyperglycemia in itself causes polyuria. Okay, so your hyperglycemic patients generally are producing more urine than normal. However, those who are coming into an emergency department with extremely high HTTs are generally dehydrated. So you don't always get it, okay? But it's just something you have to look out for, right? The only problem is we only achieved a 50% rate of compliance. So that means half of our patients weren't maintained correctly, all right? They were basically given too much or too little fluids, or they had no catheter inserted. So if there's no catheter inserted in these HTT patients, you don't know how well you're doing, all right? So it's important, it's important. Now, when I say that, I mean, you get some of these patients, the HTT is like 20, you know, you're just gonna give a bit of subcut, act rapid, and you're gonna, give them a bit of fluids, you're gonna be okay. You don't have to catheterize those. But if your DKA comes in, your HHS comes in, the severe hypoglycemic and you're not sure where they fall, try and put a catheter in just to make sure, right? So yeah, one patient, we had too little fluid prescribed and it correlated poor urine output. One patient was placed on crystalloid fluid rather than glucose for hypoglycemia. Okay, so if you put normal saline or Ringer's lactate on a patient who's got low sugars, you keep on dropping their sugars. So it's one of the worst things that you can do. Luckily, somebody saw it. It was noted in the notes, and they changed it after 10 minutes. Right? It's an innocent mistake. It can happen. You know, you think you look down. There's the 5% glucose. Somebody calls you. Your hand goes down. You pick up Ringer's lactate by mistake because you're right next door to one another. Just don't do it on purpose. Okay, that's the thing. Okay. Right. Then the other thing was correct investigations. Okay. So sepsis. One of the most common reasons for our patients to become hyperglycemic. We saw it during COVID. We see it with our hypoglycemic patients, especially the elderly, even though most of them have overdosed on their medication, but sometimes there's an element of sepsis as well that's causing this. So how do you screen for sepsis? What do you do? Any idea? You're right, you just got to say it a bit louder. Yes, yeah. You need all of those things, which are going to take quite a bit of time. It will take about a day to come back. So the first thing you do is your patient pyrexic. Does your patient have anything in the urine? Does your patient have obvious clinical signs of infections, you know, diabetic feet, things like that? And thereafter, exactly as Dr. Mtadi said, you do all of those things as well, right? Because you want to see what's going on, all right? Then you have to check all of your hyperglycemic patients need an arterial blood gas. Any idea why? Very good to screen for acidosis, because some of our patients, even though they are DKAs, they don't produce ketones in the urine. Does anybody know why? You're close, yeah. Yeah, so it can be non-ketotic in the urine, all right? So what happens is in the urine, we produce two types, or in our body, we produce two types of ketones, all right? Ketoic acid, all right? And beta hydroxybutyric acid. Don't worry if you don't remember those. I'm just telling you those are the two. But when we test the urine, we're only checking for ketoic acid. The problem is in the body, the second one outnumbers that by 15-1. So in other words, you've got this whole lot of ketones that are sitting in the body, but they're not coming out in the urine because the numbers are so different. So you've only got, for example, 2 ketoic acids and you've got 30 butyric, all right? So when the urine comes out, it's a bit diluted, you put it in, there's no ketones. In the meantime, this patient is acidotic, all right? The other reasons you need your ABG, potassium. You need to know, is my potassium okay? If I give insulin, is it all right? I need to look at my sodium as well, all right? You tend to get dilutional hyponatremia, but you may get hypernatremia as well. It happens, very dehydrated patient. So there's quite a few things that you need to see on your blood test, which we'll talk about at some point. Where urine dipsticks are done, where baseline blood's taken, which is something you should all do. So we only got 50% right, okay. So 4 of the patients didn't have a septic screen done, okay. So that means we didn't even check we didn't write down whether there was any evidence of sepsis or not. Okay, now when we say write down, it doesn't mean that you must go through everything. You know that I checked the chest and in the right upper lobe, there was definitely no sign of a pneumonia. Then I checked the right middle lobe and there was, no, it doesn't mean that. But at least you should put patient apyrexia, nothing in the urine, no obvious clinical evidence of sepsis, all right? The thing is, it becomes a medical legal thing after that. Let's say this patient doesn't do well and this patient just needed a stat dose of antibiotics from your side. You never looked for it, so you can't really defend yourself. Okay, luckily our patients don't really sue. They do well, so it's okay, all right? And the thing is, if you don't consider sepsis and begin treatment, you'll just keep on getting your HCTs going up and up and up and up, and you don't know why, right? And especially in our elderly diabetics, UTIs are a big problem, and they're subclinical most of the time. They're not really that pyrexia, they're just out of it, so to speak, you know? It's one of the reasons that they become delirious and things like that. And then was the patient correctly disposed, all right? So should the patient have been in an ICU or high care, or was the patient supposed to be in a general ward, right? So he did quite well. There's only one patient that should have been considered for ICU, but ended up in the general ward, right? But in this case, it was based on hindsight, okay? It was the patient's pH level, lactate level, sodium level, everything, all right? So the patient at that stage had a pH that was, I think, about 6.82. All right, lactates that were already reaching about 9, and the sodium level was quite low. It was 113, but it was dilutional hyponatremia. So that was a patient that should have been considered for ICU. I understand why the doctor just admitted, because it was a 79-year-old, long-time diabetic, poor compliance, multiple admissions. So it's quite understandable that they thought, oh, I'm not waking up the physician at this time of the morning. I'll just admit the patient, we'll do the treatment like what they did the last time. But the problem is that if something had gone wrong, it would have been an issue. This patient was fine, so it was okay. All right. All right. And then how many of our patients had a good outcome? So in other words, how was it at the time of discharge? Okay. So I tried to get hold of the discharge summaries, and luckily everybody did well in spite of our little mess ups here and there. So actually the unit did quite well. That means people understand what's going on with diabetes. They know how to treat it. There's one or two small issues here and there, but it's not things that will cause death, if I can put it that way. It didn't cause, no fatal flaws. So that's a good thing for us, all right? Otherwise, management comes running after us, okay? So some of it is not due to evidence-based practice. When we say that, what we mean is that it's kind of on how I feel. That's what physician gestalt means. Physician gestalt means I look at this patient and I think this patient needs that. Not based on any empirical evidence. So it's not based on a blood gas. It's not based on what is it. It's just based on how I feel, based on my experience and things like that, which there's nothing wrong with. That's perfectly fine. Physician gestalt actually saves a lot of lives, because sometimes the empirical evidence doesn't fit what you see in front of you as well. So, you know, even though this blood gas and this, everything looks fine, but when I look at this patient is freaking sick. You know what I mean? So that's where it helps as well. But then there's the opposite as well, where we don't get the empirical evidence, we just look at the patient. So we need to have a balance between the two, all right? So always look at both. Look at your patient. As they say, you know how they always say, we don't treat x-rays, we don't treat ECGs, we treat a patient. The truth is that we treat both. You know, otherwise you just do an ECG or you just look at the patient. You have to do both, and you have to put them together, all right? So in this case, you know, it's important, but it mustn't be your guiding principle is what the patient looks like. You must also get evidence, okay, and to back you up, okay? So once you can do that, it actually becomes quite easy to manage diabetics, because diabetic emergencies are some of the easiest emergencies to manage. You're either giving the patient sugar or you're trying to drop the sugar level, okay? So that's basically what it is, all right? Now, the diabetic emergency protocols we've had in place for quite some time. It's available to all of you. I don't know if any of you have seen it though. We have looked at it. Once had a look. Yeah, saw it once, isn't it? Yeah, I know. Don't worry. I know. Nobody looks at these things. It's oh, you actually looked at it. Okay. No, that's good. That's fine. Okay. So I'm not going to go through the whole protocol. I just want to show you that it exists. All right. So, you know, it just talks about how we manage patients. Okay. So we go through all of these things and we try and figure out whether the patient is, for example, a DKA, whether a patient is an, you can come through. Okay. No problem. You know, whether the patient is, well, it used to be called HONC, but now we call it HHS, all right? I just wanted to stop for a little while on this, all right? We'll cover it as well again some other time, but it's potassium replacement in a patient who's got DKAs or HHS or whatever it may be, all right? We can't say that because our patient has a low potassium, we're not going to give insulin to this patient. Insulin has to be given to a hyperglycemic patient. But like we say, if we give insulin, we're going to drop potassium. So the way that we solve that problem is, while we are giving insulin, we give potassium at the same time. The question is, how much do we give? All right. So there's quite a few regimens out there. This is the one that we use here, all right? So if your potassium is less than 3, you give 40 millimoles, which is basically 2 amps in a liter of fluid. Now, Ringer's lactate is better because Ringer's lactate already has potassium in it as well, okay? And then so on and so forth. You know, you keep on going down until you see. Generally, if your K plus is about 4.5, you don't have to give 10 millimoles or the half an M, because, how do I explain? It's your patient's, I just want to put it in a way that that's understandable. It depends on your patient's condition, if I can put it that way. But if your patient is less than 3 to 4, start thinking about supplementing the potassium at the same point, all right? The question is, how do you give potassium? Because remember, you can't give potassium as a bolus, all right? If you give potassium as a bolus, that's what's known as a lethal injection in Texas, all right? That's how they kill people in Texas, all right? When they want to kill them, they give them a bolus of KCl along with some other sedatives, and that's how you die, okay? So when you give KCl, it has to be infused slowly. So we have two types of lines. We have peripheral lines and we have central lines. So depending on which one you have up, that will determine your rate. If you have a, what you call it, a peripheral lineup, you generally run your potassium at 10 millimoles per hour. In other words, half an amp per hour. If you have a central lineup, you can give a full amp per hour. Just remember that, okay? And then depending on how much you need to give. So example, you've got a very severe DKA with the potassium that's sitting at about 1.2. You may even decide I want to give 3 amps over the next few hours, just as an example. It's no use having a peripheral lineup. You need to put a central line because it means you can give it at a faster rate, okay? So these are the things that you have to consider. And once you start supplementing potassium and you start giving these infusions, make sure you repeat everything on an hourly basis until the patient goes to ICU, all right? Right, so DKA just covers all of that and what you should look for and basically all of that, also the same thing all and over again. I just copy and pasted quite a bit of it, okay? Just want to go to it maybe. Yes, acidosis. When do we use sodium bicarbonate? Okay, sodium bicarbonate works on the rule of sevens because soda bic will bring up your pH, but it will drop your potassium as well. So you give it when your pH is less than 7 or your potassium is above 7, all right? What I would like all of you guys to do is go and have a look at acidosis and potassium, okay? Because there is something called adjusted potassium in acidosis. To basically, the lower your pH, the higher your actual potassium is, all right? So what it's reflecting over there is actually below what it is. So there's a nice calculator that's out there to work it out, right? But I don't want to spend too much time on it now. We'll cover it when we cover hyperkalemia at some point, all right? And I just want to see if there's anything else that we need to go through. So HHS, do you guys know about HHS? What used to be called HONC? Hyperosmolar, yeah. Now it's known as hyperosmolar hyperglycemic state, HHS, right? So basically what it means, your patient doesn't have ketones, but your patient has got a decreased level of consciousness is due to the hyperosmolarity of the blood with all of the glucose inside. So it's exactly what I was describing earlier, all of that water getting drawn out, cerebral cell shrinkage, and that's basically what causes it, all right, along with electrolyte disturbances and that. These tend to be mainly elderly patients with infections, all right? They've been sick for quite some time as compared to DKAs who get sick very quickly, all right? They often have focal neurological signs, often profoundly dehydrated, okay? So it's important that, you know, like I say, I'm not going through all of this. You guys must read this and you guys must know it, okay? But the most important thing, even with your HHS, is not to overload them with fluids because they're even more susceptible to cerebral edema and dying. And the truth is cerebral edema has twice the mortality rate of DKA and HHS. So giving too many fluids, not a good thing. It's very easy. You can say, you know, this patient looks very dehydrated, put up 4 lines, open all of them and walk away. You have killed your patient, basically. It's kind of like saying, well, this patient has a severe headache. They'll need 20 Panados over the next 3 days. Let me just give them all right now. You get what I mean? It's the equivalent, you know, your fluids are medication, so make sure that you use them in a proper way, okay? This is, again, how IV potassium should be used and how we should go about it, all right? So I'm not going to concentrate too much on that. I just wanted to show you guys this, all right? So there's a checklist if you are still a bit lost of what to do, okay? So, and I wish I could turn it around, not sure how, but anyway, it's here in A&E and it's in the protocols as well, right? So what it does is it's a quick yes, no to try and help you determine what's going on, right? So have you done your dipsticks? Have you done your fluids? What have you done with your fluids? If you've taken your ABG, what have you found on your ABG and things like that, right? So what it does is it guides you as you are going through your patient, all right, with commentary on what you should do, should you find a certain finding, okay? So if you have something like this, even the guys who are not here at Madadeni, if you have something like this, keep it in your emergency area, just so that you've got something, all right? So this is, well, this is supposed to be the first part, sorry, page 1. So what you should ask for on history, okay? So basically the audit part of it, what you can say is that we did quite well, okay? There were some times where it was just the feelings of the doctor rather than the evidence, but nevertheless, that means most of the feelings were fine. You know, the guys did okay. Now, this was not actually you guys. You must remember most of these patients were from mid-December, so it was the previous group. And the previous group then, you know, had seen the majority of the patients. I think there were only 1 or 2 from this year's group because I knew you guys were just starting off. That means people actually did quite well, you know. That's the thing. But remember, the guys who were finishing off last year had been doing this for almost 12 months and they were still making mistakes, you know, small mistakes, but nevertheless, still mistakes. And diabetic emergencies are not something we see once a week or twice a week. We see them every day, multiple times a day. So it's one of those things that you just need to know exactly what you are doing, right? Regardless of where you work, you know. So it's an important thing to know. It's an important thing to keep on revising. It's an important thing to have at the back of your mind whenever a patient comes in, that this and this and this is what I'm going to do. But the one thing I will advise you guys, do not, and I repeat, do not give insulin until you know the potassium levels, okay? If you are lucky, patient's already got high potassium, you didn't cause any problems. But if that patient has low potassium and you give this insulin in, you've killed your patient, okay? So to finish off, let me just find the right one here. Right, we're just gonna ask some basic questions, all right? So people on Zoom can also vote as well. We're gonna answer for us. I know it's a bit difficult to read, so I'll just read it out for you, right? All of them are true or false, so you can tell me true or false. Clinical audits are similar to research, true or false? Sorry? True, very good, okay. Hypoglycemic patients should always be bolused with 40 mL of 3% hypertonic saline. Sure. What should they be bolused with? Yes, 40 mL, 50% dextrose. Yeah, very good. Sorry. I don't know what I did over there. Sorry. Okay. Sorry about that. I just pressed the wrong thing. Okay, where were we? Number 3. Hyperglycemic patients are generally dehydrated and respond well to fluids. True or false? Very good. Okay. We should always rush to give insulin as soon as we see the blood sugar levels are elevated. False. Okay. We should always try and wait for potassium in our very sick patients. Okay. And an ABG should be done on all patients with high blood sugar levels. True or false? True. Very good. Okay. So thanks for everybody on Zoom not voting. I really appreciate it. 1 person voted. Okay. I think after hearing all the answers. No, I'm just kidding. Okay. So you guys can carry on voting on Zoom in the meantime. Oh, okay. Yeah. So it's easier once we give the answers. I know. All right. So I hope you guys learned something from that. Clinical audits are boring. I hate them. I have to do them every month. And unfortunately, we have to sit for the meeting every month. It's part of our requirements as a department. Okay, but at least we have proof that we are doing it. Okay, so next month I've already completed. It's about anemia. Unfortunately, we didn't do as well. This month we did quite well. Oh, next month is bad. So tomorrow what we're going to do is we're going to do eye trauma. It's quite important because it's something we don't really learn about. So I hope you guys will be a bit more excited for that instead of these boring clinical audit type things, all right? Yeah, exactly. I become the optal on call when the optals are gone. That's why I had to learn all of that stuff. So, you know, eye trauma, very interesting topic. There's a lot that we need to learn tomorrow. And you guys will enjoy it. We've got quite a nice video and a couple of good pictures just to show you guys. So I hope it will go okay. And yeah, I'm not sure if there's any questions or anything that anybody wants to know. One thing on the chat. Or if the ABG machine wasn't working, that's actually a very good point. How do we handle these patients? What you need then is you need potassium, all right? You need at least your potassium level and you need your bicarb levels, which you can get just on a yellow tube, all right? So if you can get that, if you can monitor your potassium, you can monitor your bicarb levels. Generally, when your patient has severe acidosis, in order to compensate, unless they've got renal failure, their bicarb levels will start to drop as well, okay, as they start to use up their bicarb. right, in an effort to what you call it, compensate for the acidosis. Okay, yeah. Urgent, yeah. DK, yeah, and bicarb, exactly. It can come, yeah, within a few minutes, so it's fine. So definitely you can get it, within a few minutes. That's basically all that you need, and an HTT machine. So you just need to be able to follow the blood sugars, or every couple of minutes just to know what you are doing. But ideally, you should have a blood gas available. But I know, actually, Dr. Masilela is right. There's sometimes when we don't have it. But at least if you have your potassium and you have your bicarb levels, you can at least manage your patient. If you want to be really, really thorough, then you do lactate levels as well. So a little gray tube that we use normally for CSF glucose, you take that, fill that with blood as well, put it on ice, and you get a frozen lactate level. So you can monitor your lactate levels as well to see if you're making any improvement or not. Okay, but it's difficult to do it that way, that's for sure. Okay, so yeah, I hope that was okay. Any other questions? Anything else anybody else would like to know? Everybody okay? Yeah. Yeah, in terms of milliosmoles, you have to be able to work out your milliosmoles, right, at the end of the day. So there is a formula to work it out. It's basically 2 times sodium plus your glucose plus your urea, and I think calcium they've added now as well. And it needs to be above 350. The thing is, at the end of the day, in our case, whether it's HHS or it's DKA, we're treating it more or less the same way. What will change thereafter is based on what they find, when the patient's in ICU and things like that. But you are correct. If it's less than that, you generally treat it as a DKA. However, you can get HHHs that are acidotic as well, but their acidosis may be linked more to the lactates as compared to the actual ketone amount, And it's quite a complex subject, actually, when you really think about it. But you're 100% right. That is how you work out your osmolarity. And then there's some where you've got, for example, dilutional hyponatremia. So what happens is initially, you don't see that you've got a hyposmolar patient because when you're multiplying your sodium, it's not coming out to that much. So that's where it can become a bit difficult. That's when you specialize as an intensivist, you learn how to actually correct for that. In the emergency department, it doesn't make a difference to us. Whether the patient is HHS or DKA, we're treating the same way. We're giving them fluids, we're trying to bring down their potassiums or increase the potassiums, give them insulin, and make sure that their hydration status improves. That's basically what we are trying to do. And if you can do that, 90% of the time, you'll keep your patient safe. Remember, a DKA and an HHS is never going to resolve in an emergency department. Never, ever. NIN gap, you can rely on. No, you can rely on the NIN gap, but that's what I'm saying. Now, you're going to be sitting and working out all those formulas for so long that by the time you do all of that, it's still not going to change your treatment in the emergency department. The only thing it's going to change is that when the physician walks in, you're going to say, this is definitely an HHS based on, and you're going to take out your page of calculations, and they're going to give you a round of applause, and you're still treating your patient the exact same way. So it's a good thing to know, but does it affect our actual treatment? No, it doesn't. We're still treating both the patients in almost the exact same manner. But you're 100% right that you should know these formulas, especially if you end up doing an ICU rotation. Then it will definitely help you, no doubt. And NIN gap definitely plays a big role in all of that. And when we're covering ABGs, then we'll look at that as well. Okay. But what I'm talking about is us sitting in our emergency department. What are we looking for? And what are we looking to treat? So, but you're 100% right. I can't argue with you. That NIN gap will actually help you along to determine between your HHS and your DKA. Yeah. So that's very good. And, yeah. Okay, so the question is, when do we hand over the patient? Now at Madadeni, we hand over the patient once we've gotten to the point of insulin infusion. All right, when we say stable, all right, so in other words, we have started replacing or reducing potassium. We've started fluids. We've determined it is a diabetic emergency, be it HHS or DKA, based on either formulas or based on what we can see from history. And then we say, right now we've got our insulin infusion running. Our patient is stable. There's not much more that we are going to do here. Because from that point on, the patient needs monitoring. That's it. And A&E or in any emergency casualty is not a place for monitoring. It's a place for stabilization. So it's at that point. If you've got potassiums that are still sitting at 7.5 and you've started your insulin infusion, That's not the point to hand over. You've still got to drop your potassium. You've still got to treat that part of it, get your patient a bit more stable, and then pass your patient on. In other words, when your physician walks in, your physician must say, listen, this is a bad DKA or bad HHS. I'm taking this patient to ICU. I'm taking this patient to the ward based on what you've already done. So in fact, we do quite a bit, the majority of the initial work, and then they do the monitoring thereafter and management and to make sure, right? That brings me to another thing. When you are doing an insulin infusion and you're busy doing other things, make sure you're not dropping your glucose too quickly as well, all right? So the most common way to start our infusions in adult patients, like we don't have 50 ml bags. So we put 200 units of actrapid, 200 mils of normal saline, and we run it at 5 mils per hour, and then based on how HTT is dropping, then you increase or decrease. But that's a whole separate topic altogether. I've got it on another lecture. I don't want to get into it too much, otherwise we're sitting here the whole day. Okay, of how you do it. There's a specific formula to actually work it out. That's quite easy to remember, but that's the point of handover. Okay, when your patient is relatively stable. Now, when I say relatively stable, that means there's not much more that you can do. Let's say even you've got the potassium that's high, but you are dropping it. It's not your job now to make sure it's right back down to normal before you hand the patient over, but at least you know that it's being sorted out, so then they can take over after that. Otherwise, DKAs will sit with you, HHS will sit with you for 16, 20 hours. We had a big fight with them recently because the physicians were all saying, yeah, listen, give the patient 4 liters at 250 mils per hour, then we'll come and see the patient. I'm like, dude, that's 16 hours you want this patient to sit here. And then they realized, oh yeah, that's right. We are asking to wait the 16 hours. And we had quite a few of them because they decided to change their own internal protocol, So we had quite a big fight with them. It's like, no, you can't do that, not at all. Yeah. Yes, exactly. Yeah, and then when that patient dies from cerebral edema, that's when they'll blame you as well, because they'll come and say, look at what this doctor did. You know what I'm saying? That's why I say there are quite a few regimens out there. I'm just saying the one that I gave you is safe. You won't kill your patient. You won't necessarily rehydrate your patient as quickly, but at least you won't kill your patient by using that one, And that's where the problem comes about in the emergency department, because we are essentially the first responders. When things go wrong 3 days down the line, we still come back to what happened at first. Do you get what I'm saying? So if you were to give 2 liters in an hour and that patient dies of cerebral edema 2 weeks later, they're going to come back to you and say, you are the one who actually caused the problem, not us. I've sat in M&Ms for patients who have been in wards for 2 months. And the main discussion is what happened in the 2 hours in A&E. 2 months later, the patients died. And I stood up, I still remember standing up in one meeting and saying, this is bullshit. Yeah. Look at what you guys did. Then everybody sits quietly, because A&E is an easy place to blame, because we see the patient for a short while, we see them at their least stable, and we have to stabilize as much as possible in the shortest time possible and then get them off. So it is important that you cover yourself with protocols, regimens that are not going to get you into trouble. They won't necessarily sort everything out, but they also won't kill your patient at the same time. So that's why you do that. And always remember, like for instance, somebody told you that, you note down, Dr. So-and-so told me, give . So when something goes wrong, you say, no, this is not my protocol. This is what I was told by Dr. So-and-so to give, so I followed it. Okay. All right, guys, it's almost 9 o'clock. I think everybody must be tired by now. Can we stop? All right, no problem. Okay, thanks to everybody on Zoom as well. Oh, guys, do you still have questions? Oh, okay, thank you. All right, no problem. Thanks, Mr. All right, so we're going to end the meeting over there. Thank you, everybody. Hopefully I should get your ethics points soon. Thanks, bye.